Welcome, everybody, to Rush University Medical Center Division of Nephrology Renal Biopsy Conference for September 15th, 2022. We do not have a CME activity code today. Apologize for that. The conference is being recorded and will be uploaded on YouTube shortly. We're a little bit behind. We apologize for that, but we'll catch up shortly. We have nothing to disclose. We do try to maintain patient confidentiality by changing the name, the dates, and everything else associated with the patient. And we've got a great case today. It's a case Dr. Corbett's going, it's a case of Dr. Corbett's. Dr. Patel, Neelam Patel is going to read the protocol shortly. If you're not on our mailing list and want to, just send us an email. We'd love to have you. We tell all your friends, the more the merrier, etc. Everyone will be muted except for the faculty. But please use the chat box to ask any questions. We'll try to address them as we go along. Let's get started. Neelam, you want to walk us through this case?
A 45-year-old Asian man presents for evaluation of microscopic hematuria, microalbuminuria, and chronic kidney disease. He has a history of severe psoriasis and psoriatic arthritis since 1990s, on infliximab since 2005, gout on allopurinol since 2010, and hypertension since 2010 on hydrochlorothiazide and thelmisartan. He was seen by urology in 2020 for microscopic hematuria, and a CT scan of the abdomen and pelvis was normal. A cystoscopy was not performed. The microscopic hematuria persisted, and in June 2021, the serum creatinine was 1.34 milligrams per deciliter with a GFR of 64 milliliters per minute. In March 2022, the serum creatinine was 1.45 milligrams per deciliter with a GFR of 57 milliliters per minute. The urine analysis had large blood by dipstick, and a UPC was 217 milligrams per gram. An extensive serological workup was done, revealing an elevated C-ANCA titer of 1 to 320 and an anti-PR3 greater than 100. By July 2022, the serum creatinine was 1.54, and he continued to have microscopic hematuria and proteinuria. He was then referred to nephrology for evaluation. On review of system, he was positive for joint pains, rash, psoriasis, and pruritus. He denied any gross hematuria. His past medical history was positive for severe psoriasis and psoriatic arthritis since the 1990s, gout since 2010, and hypertension since 2010. His surgical history was positive for an Achilles tendon repair several years ago. On social history, he denied any tobacco, recreational drug, or alcohol use, and his family history was notable for a father with type 2 diabetes. He had no allergies, and his medication list included hydrochlorothiazide 25 milligrams daily, infliximab 600 milligrams every 6 weeks since 2005, metoprolol 100 milligrams daily, thelmisartan 40 milligrams daily, and allopurinol 600 daily. On exam, his blood pressure was 140/88, heart rate was 75, respiratory rate of 16. He was afebrile, and he had a BMI of 40. His exam was unremarkable, besides for a macular papular rash along his upper extremities bilaterally and large confluent erythematous non-blanchable patches along his lower shins with a macular papular rash along his thighs. In terms of his labs, his CMP had a sodium of 138, potassium of 3.7, chloride of 103, bicarb 20, BUN 17, creatinine 1.54, GFR of 53, glucose was 91, calcium was 9.6, total protein was 8.3, albumin was 4, total bili was 0.9, and ALK phos was 65, and AST 27, and ALT was 35. On his CBC, his white count was 8.3, hemoglobin was 13.8, platelets were 238. The UA, the specimen was clear with a specific gravity of 1.014, a pH of 6.5. It had 1+ protein and 2+ blood with 21 RBCs on the high power field. His urine protein creatinine ratio was 275 milligrams per gram. and his urine albumin creatinine ratio was 125 milligrams per gram. His serological workup, including HIV, hepatitis A antibody, hepatitis B antigen, hepatitis C antibody, rheumatoid factor, anti-double-stranded DNA, ANA, C3, C4, RNP antibodies, anti-Smith antibodies, scleroderma antibody, SSA and SSB, anti-Jo1, anti-cardiolipin-1 antibody, beta-2 glycoprotein 1 antibody were all negative or normal. His C-ANCA titer was 1 to 320, with a P-ANCA titer of less than 1 to 20 and a PR3 antibody that was greater than 100. The CT abdomen pelvis showed symmetric appearing kidneys bilaterally without any hydronephrosis, calculi, or perinephric stranding. The renal ultrasound with Doppler showed that the kidneys were normal in size and echogenicity without any hydronephrosis, mass, or cyst. There was no renal artery stenosis, and there were normal resistive indices bilaterally. And then the patient underwent a percutaneous renal biopsy.
Just to get this out there, the rash that he had was consistent with his psoriasis. This was not like palpable purpura. The other term we should have added to was kind of scaly looking. I mean, it looks psoriatic in nature, not palpable purpura, if you will.
Thank you, Neelam. Anybody have any other questions or regarding the protocol? Great. Dr. Gash, do you want to tell us your thoughts?
Yes. So we have a 45-year-old gentleman who has a creatinine of 1.5. He has hematuria, and he's got psoriasis and is getting some biological agents for treatment of that. So obviously the differential diagnosis for somebody who has hematuria, especially in an Asian male, we have to think about IgA nephropathy. So that's pretty high on the list. The amount of proteinuria is only 275 milligrams. His creatinine it's progressed a little bit, 1.3 to 1.5 in 1 year. So that is a pretty decent amount of GFR loss. So this is progressive CKD. I still think IgA is probably very likely. Obviously, the big autoimmune positive workup here is the presence of ANCA, which is usually not part of IgA. So could he have an ANCA-associated vasculitis, whether it's de novo or from some of the drugs that he's on? The TNF blockers like infliximab have been associated with an ANCA-associated vasculitis. Even allopurinol has been associated with drug-induced vasculitis. So usually in those particular cases, there's a predominance of skin involvement, and after skin is usually peripheral nerve system, and kidney involvement is actually not as common. So could he actually have that? Could the ANCA be positive because of the drugs, but he actually doesn't have any evidence of vasculitis in the kidneys? That's possible. That it's just an ANCA and not actual vasculitis in the kidney. And also it could actually be a vasculitis in the kidney. So that's, I guess, why we do the biopsy. So the only thing about the vasculitis is he looks like his creatinine has been pretty elevated for a while. And if this was truly that kind of a vasculitis, I feel like he would have been in worse renal failure. So I'm not entirely sure if we're going to see a proliferative lesion. So I'm going to go with my number one as IgA nephropathy because of his the presence of hematuria and that he's an Asian man. And if his ANCA was negative, to be honest with you, I think this would have been IgA. And then number two, I'm going to go with vasculitis, ANCA-associated vasculitis, whether secondary to infliximab or allopurinol versus just de novo.
Thank you. And I suppose there's also the possibility of infliximab causing a lupus-like, lesion. It's kind of, like a lot of these drug-related glomerulonephritides. There's be a mixture of serology and a mixture of pathology. Dr. Whittier, Dr. Gashty said IgA 3 times. Typically, when you make a call, you say 5 or 10. What are your thoughts, Bill?
I like his confidence, but I don't like his order. And I'm ready to throw down. Actually, we're going to go through an arm wrestling match here because I just can't imagine an IgA with 200 milligrams of proteinuria progressing. So IgA is clearly on there. He's an Asian guy, microscopic hematuria, but not that it can't happen, but it does seem that the progressors usually have greater than a gram of proteinuria. And seems to be a progressor based on the serum creatinine, but he's always had this just minimal tiny amount of proteinuria. So it's a little strange. So even if he does have IgA, maybe there's going to be some segmental necrotizing lesions, maybe some crescents, something like that. I just don't think it's going to be your classic slow indolent IgA with a high proteinuria. Something weird is going on here. It just doesn't the whole story doesn't fit for progressive. And then you have the PR3 that's positive. And so knowing he's progressive with a positive PR3 makes me put a little more weight into that as opposed to his demographics and the fact that he's got chronic microscopic hematuria. So I would put my top three as PR3 vasculitis, and then I would put IgA a little bit less. And when I am that confident, I am always wrong.
You're not always wrong, Bill.
95% of I'm wrong. I'm wrong the top 10 times.
Yeah, well, you're wrong on this one, but I appreciate your fake humility all the same. For either of you guys, I mean, this in the first sentence or second sentence, we got infliximab, we've got allopurinol. Casey really brought up the possibility of some drug-induced thing going on. How do you feel about infliximab? 7 to 20 some years or 17 years later finally causing a GN, or allopurinol 12 years later causing a GN. Did anybody have any thoughts on that?
From what I recall, they actually have to be on the drug for quite a while before they get the drug induced. I think I remember one paper talking about how on average they were on the drug for at least 35 months. That's like 3 years of being on a drug. And then they get biopsied and ANCA turns positive. So I don't have a problem with the duration of how long they've been on treatment. And we see this all the time with somebody else on drug for years and years, and then they develop a side effect from it. So it doesn't bother me.
Bill?
Yeah, same. I'm not going to argue that for sure.
Roger?
Yes, Dr. Glassick.
Yeah, I'm with Bill on this case because to lose this much GFR in a year with only 125 milligrams of albumin per gram of creatinine would be highly unusual. There's something else going on besides IgA nephropathy. He may have IgA nephropathy, and being Asian and having psoriatic arthritis certainly increases that likelihood. But to explain this degree of a drop in GFR based on IgA nephropathy, I don't think that washes. So I would agree with you have to look elsewhere. I would be a little bit concerned about a possible medullary angiitis in this case, because of the low level of proteinuria and the progressive disease here. And that may not show up on a kidney biopsy. I would be interested to know what the urine sediment really looks like. Are there lots of red cell casts or just hematuria?
Steve?
It was just hematuria. They didn't report red cell casts out, but he had, 21. He'd go from moderate to large dipstick positive blood with, 20, 30 red cells. But no casts were ever reported. That doesn't mean they weren't there. They may have just, as Ed always said, they sit and get sent out to a reference lab. They may just dissolve in the urine, if you will.
So, medullary angiitis, it's kind of an interesting diagnosis. I've only seen a couple cases and, read a little bit about it. But, the problem I have with the case is that no matter what he has, whether it's IgA or vasculitis or whatever, to have this kind of little proteinuria just bothers me. So.
Did we have a repeat at all? Did you have another one, Steve, in terms of
Well, he'd had one back there with the UPC was March of 2022 was 217, and then the one we did more recently was 275. So you've got
two values. Yeah.
4 or 5 months apart.
In the chat, Dr. Reen mentioned allopurinal vasculitis with the granulomatous nephritis. I mean, that's that would be certainly a lesion where you wouldn't expect much proteinuria, but you could see renal failure. I like that. And Dr. Hanasumai, I apologize for your name, for blowing your name, but he said non-glomerular involvement of ANCA, and I think that's worth bringing up, the fact that sometimes vasculitis can be preglomerular and cause renal failure. And we see it more with the larger vessel vasculitides, and they're often ANCA negative, but that doesn't really change the fact that if you have a preglomerular vasculitis, you may not see the typical urine findings that you see with vasculitis, and certainly can cause renal failure. So I think those are two good points, and thanks for.
The other thing that's interesting, this guy's on 600 milligrams of allopurinol. I don't know if anybody really noticed that, but that's a pretty good dose.
It is a good dose, yeah. Very hefty dose. Is that 3 times a day, Steve?
No, I think he was taking 300 twice a day or something of that nature. But I've seen this with some of the rheumatologists. I don't know. I used to think 300 milligrams was the max. But I've seen them now, putting them on higher doses to try and, control the uric acid level. And in all honesty, I don't remember what this gentleman's urate level was, but I just was surprised by how much he was on.
Yeah, I think so.
Was he taking anything else over the counter at all?
He wasn't. We asked him specifically about NSAIDs, and we didn't put it in here because he basically said he hadn't taken NSAIDs since 2004. So prior to that, he was. That may be a factor ultimately that we may or may not see on the biopsy, but as far as his chronic disease, but he swore up and down, and this guy's, his wife's basically a nurse. He's a pretty straight shooter. So my impression was he wasn't taking that. He wasn't taking any, Chinese herbal medicines or anything of that nature.
Yeah, because I bring that because I mean maybe he does have some IgA, and maybe the acute rise is slow smoldering interstitial nephritis from something. I mean his meds itself, I guess hydrochlorothiazide very very rarely, but maybe he's taking something else. But I guess we'll see. That's why we have to do the biopsy, I guess.
We should remember, Roger, that allopurinol is not only associated with vasculitis, also it can be a factor in granulomatous interstitial nephritis.
Yeah, that's exactly right. That's Dr. Reen had mentioned that in the chat box. Good point, though. Yeah, absolutely.
It's funny, they don't talk about it much anymore, but I remember when I studied for the boards, this was a long time ago, you talked about, this, at least with hydralazine, slow acetylators. I don't know if that same thing applies with allopurinol or not, but one dose may be more toxic for one person than another, depending upon how they metabolize it.
I think that point by Dr. Glassick and Reen is such a good one, because maybe that would be the explanation of his rising creatinine. He may have IgA and there'd be low grade of proteinuria, but without an interstitial nephritis, he may not have a rise in creatinine. And so that might really be where the creatinine rises if this ends up being IgA.
Exactly. Well, we have a poll now before. Yeah.
Now, for completion purposes, there is a significant hyperglobulinemia in this case.
There is.
Do we have a data on an SPEP or on free light chains and that sort of thing?
He didn't have any free light chains or monoclonal proteins. That's a good point.
Thank you.
Yeah, it's a really good point, because there's a big gap there, and probably it's polyclonal hypergammaglobulinemia. But yeah, we missed that. Thanks, Mario. It's a really good point. So we have a poll here that we want to run before we spin the wheel. So we have 5 choices. What is your pre-biopsy diagnosis? ANCA-associated vasculitis, that means idiopathic ANCA vasculitis. A drug-induced GN, which includes allopurinol or infliximab. Psoriatic nephropathy. IgA nephropathy, or MPGN pattern of injury. Take your time. We won't call anybody out. Please vote.
We may call him up, but that's okay.
Getting a nice turnout here. That's great.
All right, people can see the results.
So we've got about 30% say ANCA-associated vasculitis, just idiopathic. We've got 42% say a drug-induced GN. We've got one psoriatic nephropathy, 21%. So not the majority is IgA nephropathy. So I think the winner here, at least from the voting, is Team Glassick-Whittier. And Team Gashty is now running behind. So let's find out what it is. Spin the wheel, and we'll see which team wins here.
Is it already on Shintov?
No, it's on Whittier.
Yeah, then I'm going to ignore that IgA positive slide if it's on Whittier.
Well, Dr. Corbett can't read his own biopsy. I'll spin it again. All right. Mel, you want to read this?
All right, give me a second.
Dr. Oliviera is one of our second-year fellows.
Okay, can you hear me?
Yes.
Click on the screen.
This is gonna be a pressure-filled day for Melanie.
I know. I predicted that this would happen, but that's great for me. Okay, so let me advance this slide. Okay, that's the poll.
Oh my God.
A little bit of a lag for me, I think. Okay, so here we have one core stain with a trichrome stain. There doesn't appear to be much uptake of the bluish material, like particularly around the tubules. They appear like back to back. I would call this like less than 10% fibrosis overall. Maybe 10 to 20 if you look at consider this lower part.
Yeah, it was just focal around 10%. Good.
Okay.
We also had a little bit of medulla down at the very bottom left of that slide.
Okay, and here we have a glomerulus, high power, stained with PAS. Bowman's caps appears to be intact. The capillary loops are open. There maybe is a little bit of mesangial expansion in certain areas, like here and here and here.
Especially over at 5 o'clock, it's a little bit more prominent down there. Yeah.
Absolutely agree in this area. And then looking at the tubules, the brush border appears normal and intact. Yeah.
And then we have a intralobular artery to the right of the screen that looks normal.
Oh, I think my little face box is covering it. So this right here.
Okay. Yeah, over at 3 o'clock.
Yeah. Can you see my cursor? It's this right here, Dr. Simblick.
It's sitting on Bowman's capsule. Yeah, there it goes. It moved onto the artery.
Okay.
No thrombus or vasculitis in the artery.
Oh, good point. Okay.
Skip
Okay.
the slide there. Give me 1 second. Let me go back. There you go. Oh, actually, no, you're right. This is fine.
Okay. This again is another high power view of a glomerulus stained again with PAS. Again, we're seeing areas of mesangial expansion, like here, around this area here, most predominantly, but then there's some other more focal areas of mesangial expansion. Again, oh, I think I advanced. My apologies. Okay, we're back. Bowman's capsule is intact here again. Otherwise, the capillary loops look open. Looking at the tubules, again, the brush border is present. This is another artery here, Dr. Simblick.
Yeah, a little arterial. Yeah. Yeah, that looks fine. There's a little bit of periglomerular fibrosis. This area was from that area of trichrome that showed a little bit of scarring. So yeah, it's like to the right of the glomerulus, there's a little interstitial fibrosis, and some of these tubules are a little bit atrophic.
Like these ones more here.
Yeah, yeah.
Oh,
Lag. This is a little lag. Hold on one second. There we go. This is the right. Just wait for a second. There you go.
perfect. Okay, so we have another glomerulus here, stained with H&E stain. Here, looking mostly for areas of like hypercellularity. So maybe some hypercellularity here.
Yeah, so that's right at the hilum. So you want to look out towards the periphery a little bit more, but maybe like around 3 o'clock, if you keep going down, I see, yeah, right there. It's a mesangial area with 4 nuclei. Yep.
Right. Then the capillary loops look open. This pinkish material, is this like an area of necrosis?
No, no, that's not. These are unliced red cells.
Got it. I mean, it doesn't.
Right. Yeah, we don't see any chirectic debris. We don't see any fibrin. These are just unliced red cells. And in fact, if you look outside to the peritubular capillary at 9 o'clock, you could see unliced red cells in that one also.
Like,
Yeah.
in this
Yeah.
area.
Yeah. Yep. Outside the glomerulus, I meant. Yeah.
Hey, Mel, so far, what do you feel comfortable excluding, and what do you feel comfortable not excluding?
So I think based on what I've seen in terms of the vasculature on the biopsy, I don't think that this is so much a vasculitis, and with like the mesangial expansion and hypercellularity in those areas, maybe pointing more towards IgA.
Yeah, I think that's that was what I was getting at. Although I'm not that impressed by the mesangial disease,
No.
but that's what we got. So I think that's exactly right, Mel.
Okay, let's see here. Okay, so here is the silver stain, mostly looking at the capillary loops for any spikes or holes, which I'm not seeing. Just making my way around. Everything looks quite normal to me.
Yep. Yeah, I agree with you. No ruptures or spikes or holes.
No.
Oh, down falls Whittier. Oh,
So David, this was a different patient, right? Clearly, this is not the right one.
I think this is IgG. I don't think it's IgA. I think you just mislabeled it.
Yeah.
The floater.
Yeah, we've got positive for immunofluorescence of IgA in the areas of the mesangium, which is kind of consistent with I guess Dr. Gashti's hypothesis. Good job.
It's really nice. These things don't always correlate, but that's a really nice immunofluorescence. And considering what I was saying, that the light part of it is pretty boring. The immunofluorescence is very impressive, and I don't think it doesn't mean anything. It's a really beautiful example of IgA nephropathy with immunofluorescence. Really, it's all in the mesangium. Occasionally we'll see it's peripheral, but that's beautiful mesangial IgA.
Mm-hmm. Oh, I went back too far. Okay, now it feels like a little bit like cheating looking at the electron microscopic portion of the biopsy. So I'm here essentially looking for areas of mesangial deposits, and you can see, maybe, I don't know if I can see any here.
Yeah, move your arrow up. Yeah. We'll see those at higher power, but there's some small scattered deposits in there.
Mm-hmm.
And then over, if you move straight over to the left and down a little bit. Yeah,
Oh,
yeah, there you go.
Yeah. Okay. Otherwise, the foot processes they appear intact, maybe some areas of focal effacement, but I can see the slit diaphragms.
Yeah, just focal effacement.
Mhm.
Yeah, I can advance it now. Give me one
I
second.
think that every time the chat box comments,
Yeah, I
like,
can. Oh, you
thank
got it?
you.
Okay.
Okay, so this is another electron microscopic view of the biopsy.
Here we go. This is
I-
a better one. Go ahead.
Okay, yeah, I think I finally caught up. So here we can see the electron dense deposits here and along here. Maybe some
Where they're located?
here, is this
Yeah.
one? Would this be one like big confluent one?
It's in the mesangial area. You've got two loops right there, and this is the mesangium in between.
Like this area here?
Yeah.
Yeah.
You see the red cell on the right, and then you can
Yes.
also see on the left, you can see the lumen as well. And so that's the mesangium right between those two capillary loops.
Right here, got it, okay. So it's mostly, this is the part that we're mostly focusing on.
Yeah, those are actually, very nice, large electron dense deposits in the mesangium, consistent with our immunofluorescent diagnosis.
Can advance it. Yeah, this is the last one. Go ahead.
Okay. So here, let's see if I'm trying to, so here would be the area of the mesangium. Are these the electron deposits in this area here that we're seeing?
Yep.
Exactly.
Yep. We got a high power of a pretty much exclusively a mesangial area.
Mhm.
Yeah, you're highlighting the mesangial deposits.
Exactly.
So,
What's your diagnosis, Mel?
IgA nephropathy.
Yeah, I think unfortunately that's all we found. There were questions. Yeah, Bill's pouting. There were questions about the medulla. There was questions about preglomerular vessels, since we brought that up in the discussion. I don't think David saw any evidence of large vessel vasculitis. I don't know about the medulla.
Now, the small portion of sample medulla was normal.
Okay. So kind of the pathologic diagnosis, the histologic diagnosis of IgA nephropathy, one of the questions is coming up here, and a lot of it's in the chat, is that, Dr. Gashi said, I don't see a creatinine of, 1.5 or whatever it is. I don't see a creatinine of 1.5 here. Other was brought up, well, maybe occasionally if in IgA nephropathy, you get red cell casts enough to cause renal failure, presumably from hemoglobinuria, although, that's not really known exactly the pathophysiology, but we didn't see that either. So it is a little bit of a mystery, this degree of renal insufficiency. And even the IFTA, the IFTA on the original, we were talking about 10% or something, and nothing really fits. So I think those are all really good points. I'm not saying I have an answer or that we'll have an answer, but I think we all expected to see a lot more than just, if I saw this biopsy, I would be thinking this is a mild IgA nephropathy. Patient's creatinine might be 0.8 and might have 400 milligrams of protein or 800 milligrams of protein or something, but I certainly wouldn't have expected that degree of chronic renal insufficiency. So I think that may remain unexplained. And anybody else have any comments about the pathology before Dr. Corbett discusses the case for us?
David, the interstitial, the IFTA was 10%. The glomerular sclerosis was also around the same 10%.
18%.
Okay.
There were 2 gloms out of 11 total in the biopsy, including the immunofluorescence, that had globally sclerotic scars. That came out to be around 18-20%.
And Bill makes a good point that the PR3 could be, medication related. It doesn't mean it's pathologic. And
Well, I think especially you look when you see greater than 100 PR3. I mean, that's kind of the situation. I think we think about drug-induced forms of ankylosing, if you will. I think that's the thing that caught my eye initially when this particular physician, who's a rheumatologist, does, he does blood work, he's got a panel that literally picks up every antibody known to God. And when I had to do a double take when I saw how high this, I mean, it was at the upper, they couldn't measure it. It was higher than what the upper limit was. So that was the first thing that kind of caught my eye, thinking about at least a drug-induced ANCA in this situation.
Yeah, exactly.
I'm assuming you decreased allopurinol at some point though, or stopped it, or I guess you'll talk about that, but.
Dr. Reed had mentioned that allopurinol is more likely to have toxicity in the Asian population. I wasn't aware of that. I think Steve was kind of asking something about maybe that as well. Dr. Reed, do you want to say a little bit about that if you're able to turn your microphone on? And
Give me 1 second, I'll let you do that.
there you go.
There you go. Actually, there is a BHLA, HLA-B57, which is found in mostly East Asians, and there is a higher incidence of toxicity of allopurinol. It is well documented. I'll find a reference and post it for you. I have seen few patients with that. So I actually, in my own practice, I never use allopurinol in Asian person. I actually use other drugs to control gout, remission of gout. But I will encourage everybody to be very careful using these drugs in Asian people. When I say Asian people, it means not the South Asian, East Asian.
And that's interesting. I had no idea that. That's really, it's very interesting information. And yet, one of these things that always come out of these conferences.
Do you use
You never know.
fluoxetine? Do you use Uloric as a replacement, or?
Yeah, I use Uloric in that situation.
Dr. Gashi says I would stop the drugs because still could become an issue down the road. And I think that's a good point, which, we'll press Dr. Corbett about what he did when he tells us about the case. Steve, you want to take it over?
Sure. I just have a few slides. Now I'm nervous, Mel, because Dr. Glassick probably knows more about this than anybody I know. So here we go. With IgA nephropathy in general, we've got T cell activation, which activates, and BAF and APRIL, or B cell activating factor and A proliferation inducing ligand, which are both TNF-alpha of the TNF-alpha family, are upregulated. The plasma cells then produce, or B cells produce plasma cells that make this abnormally galactosylated IgA. And interestingly, IgA1 is normally a monomeric IgA, and IgA2 is usually polymeric, which is usually seen on mucosal surfaces. And if I recall, years ago, it was originally thought, since this was a polymeric IgA that they were isolating, it was originally thought it was IgA2, and then ultimately found out to be IgA1 that has this J chain that connects them. And here's the hinge region where the area of abnormal galactosylation is in the O-glycan area. To this, an IgG antibody forms that can form these immune complexes. And to my knowledge, IgA and IgA can actually, co-aggregate as well, forming immune complexes, which then deposit in the mesangium and cause inflammation and IgA nephropathy. In addition, I think the abnormal galactosylation also alters its ability to be cleared by the liver, from what I've read as well. Go ahead. You can keep in mind there are a number of secondary causes of IgA. And this list goes through the litany of things that have been associated with it, many of which people have brought up today. I remember dermatitis herpetiformis, I have to admit, and I wasn't certain about the psoriasis, but definitely it has been associated as well. Some of these secondary forms of IgA are thought to be, the term that's used is lanthanic, which basically means you'll find IgA, but it doesn't necessarily go on to be, pathologic, if you will. And my recollection is that's kind of the situation with cirrhosis, where they don't clear it. But most of these people we see with cirrhosis might have some microscopic hematuria, but don't usually develop significant IgA nephropathy with respect to progressive renal disease. But nonetheless, there are this whole list of things that can be associated with so-called secondary IgA nephropathy. Next. And sure enough, psoriasis, again, is one of them. And this whole area of psoriatic nephropathy The majority of the patients that have quote unquote psoriatic nephropathy have mesangial proliferative IgA nephropathy. But mesangial proliferative GN can be seen, just immune complex GN, not necessarily, without IgA, so it could be IgG. They can have FSGS, minimal change disease, MPGN. They can have, I guess, amyloidosis, because this can be a severe inflammatory disorder, especially if you have arthritis. Roger and I both thought membranous could be associated with it, because I figured membranous seems to be associated with anything, but I didn't find that. I'm sure there are case reports. In these patients with psoriasis, there's increased circulating IgA immune complexes that are noted. And they say that there's an increased prevalence of celiac disease with an increase in anti-gliadin IgA antibodies, which is basically antibodies to gluten, if you will. So that may be a factor here as well, and maybe a reason to tell people that are psoriatic to avoid avoid gluten in their diet. Next. This study looked at patients with IgA or with psoriasis, and basically found that this was done out of, I think, Philadelphia, found that in the fully adjusted model, IgA nephropathy in people with moderate to severe psoriasis. So mild psoriasis apparently involves like less than 5% of your skin. Moderate to severe psoriasis involves usually more than 5% and often involves the face, the palms of the hand, the genitals, and I assume arthritis becomes a part of this as well. And these patients usually require biologics to treat them, which is kind of where this patient fell. And if you fall into this category, your risk of IgA nephropathy is almost 5 times that of patients that don't have psoriasis. Other glomerular diseases, so other than IgA, they're still at an increased risk of having other forms of glomerular diseases, twice as likely. So as we started to kind of pursue this, Neelam and I found this paper of infliximab in a patient that had pustular psoriasis. This particular patient actually ended up having some crescents. And the next slide shows her course. I don't have the pointer, but if you look on the left, proteinuria is in the square. And at the top, you can see where they got infliximab on the up top diagram. Yeah, exactly. And that's when the proteinuria starts to rise, as does the serum creatinine, which is the little ball or the circle, the filled in circle. They do the biopsy, they make the diagnosis. And if you go back up to the top, they stop the infliximab. Of course, they start methylprednisolone and then prednisone. And this is a study from Japan, so they even did a tonsillectomy. And they switched from TNF inhibitor to, yes, that drug, Cosentyx, which is you see the commercials all the time on television. Cosentyx is basically an IL-17 inhibitor. So they flipped from a TNF and alpha inhibitor to an IL-17 inhibitor, and basically things then improved. The proteinuria essentially went away, and the creatinine came back down to under 0.8, which again is the closed-in circles. So this is at least one of a number of cases that have kind of implicated infliximab as a cause for a flare, if you will, in IgA nephropathy. Next. So the question is, why do these patients, because, in all honesty, because of the fact that APRIL and BAFF are upregulated, and those are in the TNF alpha family, you would think a TNF alpha inhibitor could be beneficial, and it is in some patients, I guess, with IgA nephropathy. But in some cases like this, it can actually cause a flare or activation. And one of the theories is that antibodies directed against glycans of the heavy chains of TNF alpha blockers may cross-react with the glycans on alpha-1 molecules to form large immune complexes. And the other thought is that somehow, aberrantly glycosylated IgA1 may bind antigenic epitopes of TNF alpha directly and form immune complexes. So whether this is the case or not, it's kind of an interesting theory as to why some patients who get TNF alpha inhibitors might actually have a, if you will, flare in their IgA nephropathy. Next. And there are cases of ANCA vasculitis, C-ANCA, with infliximab. And the theory here is that, with apoptosis, there's this nuclear and cytoplasmic debris to which the body makes antibodies, which then could, I guess, lead to the development of a C. ANCA and result in inflammation and glomerulonephritis. The other thought is that reduction in TNF alpha levels could lead to an induced autoreactivity, which enhances your potential, and as Roger said, to develop lupus, which has been reported with TNF alpha inhibitors, or in this case, C. ANCA vasculitis. It's not like there are tons of cases, but boy, you start looking and you find more and more of these things being reported, not only the C. ANCA vasculitis, but for sure, the association with flare in patients that have psoriasis. So,
Steve, don't tell us what you did. I want to talk to people.
Fair enough.
Before you tell us what you did and what your thoughts were. Casey, you win the gold award for Team Gashty and picking that it was IgA nephropathy. So I'm going to start with you. What would you do with this patient?
I'm not going to gloat about diagnosing IgA in an Asian man. But
Casey, that just makes me look more stupid now. Thank you.
No, I think that I would switch to infliximab, just because of the positive ANCA. That still concerns me, even though you may not see it on biopsy now. That may happen later. So that still is part of the management. And treatment of IgA. This is a non-vasculitic IgA. It's not even HSV. There's no systemic. It seems like renal IgA, and so I would. And it's probably secondary to psoriasis, but either way, I think it doesn't make a difference. I think it's just blood pressure control, like ACEs and ARBs. He's already on, I think, telmisartan. Yeah, that's it. I mean, there's not a whole lot. I mean, like fish oil, if you really want to, go back to the old data for fish oil, but that's about it. Nothing immunosuppressive.
It's
SGLT2 inhibitor. Yeah, that came up.
Yeah. So I have a question. I don't know the answer to that, but there's when I watch a lot of TV, and there must be, not a day goes by they don't have some commercial where somebody's jumping in the pool showing off their lack of psoriasis from one of these medications. I don't know if they're all TNF alpha blockers or not, or if there's cross reactivity or not. And does anybody know if you get a drug reaction from one that you have to avoid them all?
Well, the one that's on television most of the time with Cyndi Lauper and all those others, Cosentyx. It's the IL-17 inhibitor.
Well, there's a bunch out there. I know.
Yeah, of course. But
Phil Mickelson
one
had one.
Pardon?
Phil Mickelson was doing one. There's a lot of them out there.
Yeah,
but,
true.
I just wonder if there's cross reactivity, or if you think you're having a reaction with one, does that? And I suppose practically, it's easy. You stop it, see if the ANCA goes away, and then start something else. But Bill, what do you think? How would you? Casey's taking a very conservative approach, just cutting back on some medications. Bill, what do you think?
Yeah, I agree. And even if you're going to add some of the other extra drugs as add-ons to ARB, like eflozin or even like Plaquenil, a lot of those are proteinuria reduction as targets. And there's not that much proteinuria here. It doesn't hurt to do it, I think. But I think I'd be conservative. I would stop any potential inflammatory mediator type of drug and make sure his psoriasis is still well controlled, make sure his gout is still well controlled. Would hold the allopurinol as well, but just sort of go with conservative management. It's hard because you want to treat their proteinuria to prevent the progression, but in this case, we've kind of got a little bit of an opposite. We've kind of got a progressor without proteinuria, so there's not that much data to guide us, I think.
That's a really good point. And in the chat, it was brought up that the IgA trials excluded secondary IgA. Although I don't really know. I mean, what's our paradigm here? Secondary, Steve said psoriatic nephropathy and had a term I never was really familiar with. And then underneath it just basically described IgA nephropathy. And I think I know what he means. There's IgA nephropathy where there is no obvious cause, and then there's IgA nephropathy maybe associated with inflammatory bowel disease or celiac sprue or liver failure or something. And I think that's secondary IgA nephropathy, but we're not always sure that they're that different anyway. I mean, although certainly that was associated with liver disease tends to be more benign. Bill, would you stop allopurinol?
Yes, I would stop allopurinol, and I would switch his psoriasis treatment around too.
How about the, we saw the biopsy and it's creatinine, I can pull it back out. It's still going up. Do you think, what is this one where we've talked about, the microscopic hematuria being a bad prognosticator in these IgA patients? Because otherwise, he didn't, his pathology wasn't that impressive. And we even commented on 10% fibrosis, but his GFR was in the 30s. I don't know. I'm just trying to put it together. It seems like he's kind of progressing and I don't know what else you can really do because the proteinuria is down and I'm just open-ended question. I just don't know.
If I saw this patient, I would not think, with his level of proteinuria and what I saw in the biopsy, I would say he's got a good prognosis. The problem, as I said earlier, is his creatinine is elevated and it seems to possibly be going up even more. And I just can't put that together. I want to open up Dr. Glassick. Dr. Glassick, you were very closely involved with the most recent IgA trial, the testing trial. Would this patient have made the qualified for the trial? And what would you do for this patient?
Well, this patient would not have qualified for any of the ongoing IgA nephropathy trials, which require greater than 1 gram of proteinuria. This patient's prognosis, according to MESC scoring and the International IgA Nephropathy Scoring System, and all relevant long-term prognostic data, is that this patient would be at extremely low risk of ever developing end-stage kidney disease. However, the patient's GFR, at least if we can rely on those measurements, is declining at a rate which far exceeds that reported in any patient with IgA nephropathy with under 500 milligrams of proteinuria per day. So this is an exceptional case with progression of loss of GFR that is discordant from both the pathology perspective, that is the MES score, and the proteinuria. So, and the ANCA is positive. Something doesn't fit here.
Would you do another biopsy?
Well, we don't do biopsies with intention to gain medullary samples. Who knows what the risk would be? And I wouldn't know how to get a sample of medulla intentionally on a kidney biopsy. It's usually just an incidental finding of a too deep and too sharp an angle of the needle. I think you have to look for features of distal tubular damage, renal tubular acidosis, leukocyturia that is not explained, concentrating defects that would give you a clue that something is going on with the collecting ducts of distal nephron. Not much was present in this patient. The bicarbonate was low, but the pH was 6.5, but the specific gravity was 1.014. That implies pretty good concentrating ability. I frankly am mystified. I would stop the drugs. Would I use steroids in this case? Probably not, because I don't know what I would be treating.
Yeah, and when I was mentioned rebiopsy, I was really thinking about a sampling error, which is kind of brought up in the chat. But yeah, to get a better medullary, let's look for a sampling error and a better medullary sample as well, because the problem is, like as we keep repeating, it just doesn't. Something's missing here. That creatinine is not supported by what we saw.
And cystatin C keeps coming up in the chat too, which is fine. To use that because he was a bigger guy, I think, based on his BMI and everything there. But I think that if you have tracked creatinines over time, so at some point he's gone from 1 to 1.5, and so you don't really need a cystatin C in that situation, because at some point he was 1, he's the same weight now that he was when he's 1.5. So now if you don't have old creatinines and he's 1.5 and he's a big guy, then you don't really know if that GFR might be truly reduced. But it seems in this case it really was, although I don't have all of his creatinines over time. And you said, Steve, the rheumatologist that you let's see if the patient gets a lot of labs. So you may have quite a bit of creatinines over
So
time.
we do. I mean, we had creatinines back a number of years back that were like 1.1 or so. And then he's kind of slowly gone up. I mean, his creatinines will vacillate between, 1.2 and 1.7. And so I don't know what all the factors are involved here. These are the creatinines that we had during this period of time. But they do vacillate. One of the things I want to do is get a cystatin C as well as a CK on him. He wasn't on a statin, but I figured it'd be worth looking into that. I agree. I mean, at the end of the day, there might be a sampling error in finding the one glom that had a necrotizing lesion, but even that wouldn't explain a creatinine of 1.35 or 1.45. I mean, the interstitial looked pretty good, and that's usually more representative of function.
I just want to say what Bill's point was really good because, cystatin C is a useful tool, but I think that, when we have a delta creatinine like that, I think it takes it a little off the table. But Steve, why don't you take it and tell us what you did, what your thoughts and.
Well, when we
I
saw,
don't think we're going to explain the creatinine.
yeah, I agree. I was hoping you would, but what we did was the obvious stuff. I called the attending and just said, look, stop the allopurinol, stop the TNF alpha inhibitor until we can figure out what's going on. And I told him even after the biopsy came back, leave him off of it because I don't think anything good can come of that if he continues to have an elevated C ANCA. So they've done that. I suggested he think of something like the IL-17 inhibitor if he needs to use a biologic. He switched the allopurinol to febuxostat. And actually I found an article of urloric being associated with C ANCA as well. I mean, they're both xanthine oxidase inhibitors. So I don't know if maybe one of these other drugs that act like a lantoic, that convert urate to lantoic acid, like is what happens in birds, whether that might be better for him. I'd have to go look that up. But we had him stop those. I told him to avoid a diet and gluten, stay away from gluten. He continues on an ARB. Me, I still like Jim Donadio's studies in patients that were high risk. So I suggested they consider taking omega-3 fatty acids. It can't hurt anything. The recommendation is usually 1.9 grams of icosapentaenoic acid. In the old days, when Dr. Donadio was doing the study, that meant 6 1,000 milligram capsules twice a day. Now, many of the preparations have 450 milligrams of EPA in it, so it's only 2 capsules twice a day. And I kind of left it up to them to decide whether they wanted to take it or not. And that's where we're at. He's only a few weeks out from the biopsy. And so I'm kind of waiting a little longer. I want to check the C ANCA again and the PR3 just to see if it goes away. That's kind of where we're at this point.
That's great. Any other thoughts? Well, thank you very much. That was really a fun case, and that was a good discussion, and I think it brought up a lot of nuances of drug-induced renal disease as well as IgA nephropathy. Thank you, everybody. We will be back next week.
Thanks a lot.
Thank you, Dick. We'll be back next week with another conference. Just keep your eyes open for your emails and our tweets. And till next week, everybody stay safe.